Wadud sir, should we start now? Process shesh. Wadud sir?
Bhai.
We start now. Yes. Assalamu alaikum. Good evening, dear participants. Today is our 62nd lecture session in the banner of ECG study group. And today we have amongst us two maestros, our very popular and renowned Dr. Rafique Ahmed sir and distinguished physician Chowdhury H sir. Before starting of the process, I'd like to request Professor Abdul Chowdhury sir to say a few words regarding our presenters, and also a slight change in the routine which is going to come up in the next from January 2022 in front of you. Wadud sir.
Assalamu alaikum and good evening, everybody. Those in Dhaka and Nepal. Today, Rafique sir and Hafiz sir will be presenting some cases, particularly Rafique sir. I don't think those who are regularly present here need to hear any more about him, because they know him by their heart. He has that much influence on us, literally and ECG-wise. In both ways, he has entered our heart. And Hafiz Bhai, he's such a charming personality. And without him, we just feel that we are not having that much fun. Studying should be fun. And Rafique sir and Hafiz sir has made these things really funny, fun and amazing, and we enjoy it so much. Ladies and gentlemen, the show is open and the presentation will be started by our beloved Rafique sir.
Good evening. I think what we're going to do, we'll start with Hafiz. We're going to change the format a little bit. Normally we give questions, but today what we're going to do is we will request one of the participants to come and do discussion. So please, when we ask participation, please join. And as I always mention that, and always believe that you don't have to be right, but you have to participate in the discussion. And that's how we, other thing is that if we are always right, then we are not going to learn because I already know the thing. So to learn, I have to make mistake. That's important. But remembering that we are not going to make the mistake more than twice. That's also important so that we keep learning.
Can you see my, can you see my screen?
Yes.
EP conference, yeah.
In honor of Rafique Bhai, I'm calling it an EP conference. I will be just I will be just a presenter today. The whole thing Rafique Bhai will take over. So I'm putting the case number 2 first, because case number 1 is little heavily loaded. Therefore, I just last minute pushed it back. 70-year-old presented with palpitation for few hours. Oh, what is the EKG? Okay, now that's not good. Okay, so let's just start with case 3. 45-year-old with marijuana and potassium 3.4, troponin 560, and no other lab abnormalities. And this is the EKG. What is the diagnosis?
Tushar, it is in your domain. Will you start?
Wadud, can we have one of the participants join us, please, for this?
Hey, can somebody raise their hand and join? Find out if somebody can raise their hand. Tushar. Hello.
Sir. Hello, sir.
Can somebody join?
Just a minute, sir.
Nijam, do you want to say something about it?
Sir, noise ki tomar basha?
Tushar, tomar okhan theke noise hocche. Colonel Nijam, do you want to join?
Ribu.
Hello.
Anybody can.
Sir,
Chitrarat Sharma or Lieutenant Colonel Nijam, either one of them.
sir, shall I try, sir?
Yeah, please. Sharma, please. Let Sharma speak.
Yes, sir. Sir, with the history of chest pain and palpitation, this is narrow complex tachycardia. There is sinus tachycardia, narrow complex tachycardia with slight left axis deviation. It is regular, rhythm is regular, and coming to PR duration, I couldn't identify exact duration of the PR, but QRS is narrow complex. And coming to ST, there is ST elevation in AVR and V1, and ST depression in multiple leads B1, B1, B2, B3, V4, B5, B6, and along with 1 and 1, 2. So it could be acute ST elevation MI, probably left main or proximal LAD being the culprit visual, and that is my interpretation, sir.
Can I ask you a question?
Yes, sir.
Please stay with us.
Yes, sir.
So the rate is 187.
Yes, sir.
Okay. So look at lead V4. You defined it as a narrow QRS, but if you look at lead V4, the
yes,
QRS
sir.
is actually 120 milliseconds.
Yeah.
But in other leads, it looks apparently. So it's not by definition, it's not really a narrow QRS. Definitely tachycardia, QRS 120 milliseconds. And you said acute MI based on what?
Sir, there is ST elevation in ABR, sir. And
Okay, based on that only.
Yes, sir. And B1 also, sir.
Okay. Hafiz, any comment on that?
So this ST elevation in AVR during the time of exercise test and during the time of tachycardia,
Sir,
don't overcall it.
Yeah.
Okay, sir.
It's nullified.
Yes, sir. It could be nullified, sir.
Yes.
Okay. Also,
yeah.
QRS is wide, right, Hafiz?
Yes. So,
Yes, so
it is little bit like in the borderline zone. But before I ask Rafique Bhai to comment on that, what you describe is good, that your observation, how you conclude, that is different. Your observation was good. One thing is that I would not jump on saying it's sinus tachycardia.
Yes.
Somebody coming with palpitation and narrow complex or intermediate wide complex, whatever you say it, but if you are saying sinus tachycardia in front of the electrophysiologist, you already put the gun.
Jeopardize your career.
Yeah.
No,
So you can't.
Hafiz,
I will give a differential. I will give a differential.
Okay, I have to disagree with Hafiz. It can be sinus tachycardia, but the question is, if somebody has sinus tachycardia 187, they are going to be very sick.
Yes.
Patient have to be a very sick patient to have sinus tachycardia, but this patient was not that sick, right, Hafiz?
Right.
Sir.
And the coming with palpitation and a little bit of marijuana on board.
Exactly.
But the question is that
look at lead 2 rhythm strip.
But Rafique
Yes.
bhai, what I'm saying
What is
that
the P wave?
Yes, sir.
it is a
Yes,
good
sir.
strategy to give a differential rather than commit.
Exactly. So the comment, I mean, the comment that you made was a very high level comment. That means you went to a diagnosis of left main stenosis. I mean, it's good to keep that in mind. But as Hafiz is pointing out, so one diagnosis is sinus tachycardia. What is the second diagnosis for you?
By the way, please do not feel bad, because that is the reason I was called in, because of the suspicion of left main from the emergency room. So please don't feel bad. If it is difficult to you and the way you interpret, there are many that do it. And that's why we discuss, So don't feel bad that you concluded that way. But
So what is your second
I would be
diagnosis?
careful.
Sir, in lead 2, there is PO that is that's submerged in QRS. So it is short PR, narrow complex tachycardia.
No, don't use the term narrow, because it is not really narrow.
Okay, sir.
Okay. So if with that, what will you call the diagnosis?
Sir, probably I'd like to keep the differential diagnosis, sir.
Okay.
I like that.
Yeah.
Fine. Sinus tachycardia, one diagnosis. Second,
Yes,
what's your second diagnosis?
Another would be AVRT, sir.
Atrioventricular reentrant tachycardia, right?
Yes, sir.
Or you can say blanket supraventricular tachycardia, right?
Yes, sir. Yes, sir.
Okay, I'll come to that. So in the supraventricular tachycardia, what are the possibilities?
Sir, again, one would be the AVRT and another would be the atypical AVNRT. And
Okay. All right, so let's leave those two. I'm going to come back to that. Can this be ventricular tachycardia?
sir, ventricular tachycardia. Yeah, it is borderline. It is borderline wide complex tachycardia. That could be another differential, but B1 to B6, it is discordant. It is not concordant, sir. And RS ratio also, it is not supporting ventricular tachycardia.
Yeah.
So
Yeah. So I think when I looked at this, all this thing went through my mind.
yes, sir.
As you said, sinus tachycardia, a supraventricular tachycardia, a relatively narrow ventricular tachycardia with 1 to 100 retrograde conduction.
Yes, sir.
And then, of course, for the sinus tachycardia, our point was that patient is not too sick. I don't really see a clear P wave. It is unlikely. And you said supraventricular tachycardia, and your choice was atrioventricular reentrant tachycardia as opposed to avinodal reentrant tachycardia. Why did you choose that?
Sir, because PR interval is short here, so one of the differential diagnosis would be AVRT, sir.
Okay, so can I comment on this, or anybody else want to comment on that?
But Chitro, one thing that Rafique sir has always told us, if the P wave just after the QRS and very near the QRS complex,
Hafiz, what
Yes,
happened?
then you should
That is
consider
suggestive of
something.
AVNRT, sir.
Hafiz, the
Yeah.
ECG.
Hafiz bhai ECG রে চলে গেছে।
Okay.
Right.
So look at lead 2 in the bottom strip.
Yes, sir. Yes, sir. Now I could identify P wave just after QRS wave. So it
now
is,
what it is? What do you think it is?
yes, sir. It could first differential would be AVNRT, sir.
Perfect. So I think this is a wonderful exercise. I mean, that's what we should be doing. Remember this. I'm talking, Hafiz talking, Wadud talking. We have 35 years behind us. Hafiz is a little bit less, maybe 10 years or 15 years. Hafiz is young, and Wadud is much younger. So good.
Sir, should we consider this as delta waves in V3, V4,
Okay.
V5?
You tell me.
It seems to be like that, sir.
Okay. I mean, the question is it a delta wave? It's a possibility, but to get pre-excitation, I have to have a P wave before that, right?
Yeah.
I don't have that.
EAD
Secondly,
behind.
if it were an antidromic, atrioventricular ENT, the QRS will be really wide, right, Jamal?
Yeah.
Jamal?
Yes, sir. Yes.
Yeah.
Yeah, so it's not that wide, but keep that in mind also. Yes, if you look at lead, especially if you look at lead 2 and lead V4 looks as if there is a PXA, but there is no preceding P wave.
Sir, for the very juniors, can I explain what sir is saying? For a WPW to consider with a tachycardia, there should be a P wave in front of the so-called delta wave, but here the P wave is behind it. So this is very unlikely that there's a typical WPW related.
So this is very, very important point. Wadud এবং রফিক ভাই বললেন যে the important thing is that if the P wave is coming after, that means it is retrograde and there is a muscle to muscle conduction, the QRS will be way wider than this. That will be a differential of wide complex tachycardia.
Yes.
Rafique bhai just said it so quickly, many people may not realize this.
Exactly.
That is such an important point.
But there is an exception. If I have AV node reentry and there is a bystander accessory pathway,
Exactly, sir. Exactly, sir.
you can then
Only in that
this.
case, sir.
So
Okay.
we are going way out, but these are going to happen to us. We'll find cases like that. That somebody with AV node reentry has a bystander accessory pathway. There is partial conduction, and that's where Jamil is a thinker. He writes poetry. So he is a poet, and this is where the poetry comes in.
I faced this kind of ECG in a patient came from Cox's Bazar, and I ablated the accessory pathway, then it started doing AVNR.
That's a bystander, exactly. So what happened?
And-
You had AV node
And
reentry with
when
a
I
bystander.
tried to ablate the AVNR slow pathway, accidentally the catheter bumped up and ablated AVNR.
Okay.
Though his heart rate is above 50, he is asymptomatic. Patient is also reluctant to have a pacemaker, but that accident happened in my hand first time.
Okay,
At that
go ahead.
point-
Hafiz, continue, please.
Now at that point, Rafique bhai, it is not the patient. I get dizzy myself in those kind of situation.
I was sweating like
So-
anything.
So, okay, important question is what you are going to do next? Patient management.
Sir,
After of keeping this in differential, examining the patient, taking history, you have to make a quick decision. And I tell the fellows all the time, cardiology is such that you need to commit yourself to something. What are you going to do next?
sir,
The-
first
I
time
think
I'd
the-
like to,
Yeah, go ahead.
sir, I'd like to do for the carotid massage and Valsalva maneuver. If it is not reverted, then I'll give adenosine, sir.
After adenosine, this was the rhythm. Excellent job. So rhythm is now normal. So what do you do next?
Chitra, what will you do with this
Rafique, sir.
patient?
Yes, sir. Then it came to me sinus, normal sinus rhythm, sir. With
Can you
adenosine,
wrap it up? What is the final diagnosis?
sir, probably it is a PSBT, likely AVNRT.
And this part you may not agree. We referred for EP ablation. Will
Yes.
you agree with that?
Yes, sir, I'll agree with that, sir.
I have a question, Hafiz bhai.
The patient has cannabis addiction.
First time
It has
presentation
that
or
any role?
recurrent presentation?
Was
Hafiz
that?
bhai, is it first time presentation or it is a repeated presentation?
So this is the reason I brought this case.
Yes.
You know, for the audience, please note that two clinicians asking me two relevant questions. One, that the patient is on marijuana. And the second one is that, is it the first time? Rafique bhai will have the say finally, but you know, is it worth sending this patient for EP ablation right away after the first presentation? Or can we do a trial with beta blocker, avoidance of marijuana, and follow up and take a more rational approach? Rafique bhai.
Can we depend on the patient taking the medicine regularly? One, can he really stop marijuana? That's the problem.
Yeah.
Rafique sir.
So the question is, forget about the marijuana part. This patient came with an episode of SVT. I would like to know when was the last time the patient had SVT. If the patient never had SVT, I will go for nothing, absolutely nothing. Troponin increased, whether you want to do a coronary evaluation, means some kind of ischemia workup, that's different. But if somebody never had an SVT before, there is no need to give beta blocker even. Patient comes back in 3 months with SVT again, I will give the patient choice that, look, do you want to try beta blocker or you want to go for ablation? Today, we will probably go for ablation, recommend strongly than really going for EP. Let's say patient had an SVT 3 years ago, and this is the first recurrence after 3 years. Again, I can pursue just observation, because if I do ablation on this patient or if I treat this patient, I'll have to wait for 3 years before I can tell that my treatment has been effective. So I would go by the clinical scenario of the patient, unless somebody has any other.
Sir, I have a question. The troponin was raised and significantly. Has that any bearing whether we are going for ablation or on beta blocker?
Okay, so first of all, Wadud, I need to clarify that is a 5th generation troponin.
Oh,
so
that
this
is
like 0.5. So anything below 1, I call it mini troponin. And mini troponin can be from the tachycardia itself. So I'm not worried about that. And the LV function is normal. So I did not even do any ischemia workup in the hospital. We'll do that as an outpatient. And I really appreciate that the considerations are made, because the fellow actually sent this as a text. So we got the patient in normal rhythm, but EP ablation was recommended by the electrophysiologist because they wanted to ablate. But I was thinking that there may be a second thought, as Rafique bhai pointed out, because of the logistics and the clinical scenario, compliance and all that. And this is the first time presentation. I did not see any reason to go for ablation right away.
Rafique sir.
Exactly.
Yeah.
Can I have a question, please?
Yeah.
Sir, how is the rationale of using beta blockers or calcium channel blockers long time in a patient with say infrequent SVT also? Does that really help?
No, I already answered that question.
Yes.
It's the frequency of attack. If somebody has attack every 3 years, it does not matter what modality of treatment you apply, you have to wait for 3 years before you say that you are free of symptom. So
yeah.
No, sir. Actually, I was asking the question in the for exam purpose, not only exam purpose, but practical purpose. As in our normal routine practice, we prescribe beta blockers or calcium channel blockers to those who came to us with SVTs. And many a time we see the patients are taking these drugs for, say, for example, 2-3 years without any recurrence. And the thing is going on, the drug, he or she is taking the drugs for 2 to 3 years without any episode of palpitation. So can we use it as a pill in the pocket system, or can we have any other alternative ideas regarding use of drugs for management of SVTs?
Actually, Vishal is asking the same question. But what about we teach the patient to self-induce vomiting or Valsalva maneuver? What about that, sir?
Well, I am not a believer of pill in the pocket, simple as that. For one very specific reason. Let's say somebody goes into SVT, blood pressure was 110 baseline, goes to 85 or 90. Patient takes 120 milligram of diltiazem or whatever, blood pressure drops, and this doesn't work. And also it will take time for this medicine to work. Only PRN medicine that I like is adenosine. Short half-life, quick action. They are actually coming out with intranasal spray of calcium channel blocker, short acting. We are part of a trial that this will be given intranasally. So patient will be given that just like nitroglycerin spray. They will spray in their nose, it will work. So we'll wait. I mean, if that comes out, that will be a good medicine to use as an outpatient.
Sir, I have a question, sir. Rafique sir. Hello,
Yeah.
Rafique sir. Sir.
Yes.
Sir, the presented case, that is the case that is presented by Hafiz Bhai, that is this is the documented case, sir. This may be the first documented ECG, but before that, the patient may have the many times he or she may have the symptoms that is not documented. Many of the patient complaints are, yes, I had got the SBT, that is the palpitation, but there is no documentation. What we should do in that case, sir? That is when it will be documented first time, but patient give the history like that.
Atahar Bhai, before Rafique Bhai answers, let me tell you, the same thing our EP guy asked me. When I said, really? For EP ablation, one episode? And then the EP guy says, Dr. Gururaj actually is very good. He says, it is first time to you, but not first time to the patient.
Okay. Well, let me tell you this. So patients are not stupid. They know they have palpitation. So if patient complains of palpitation and you have one documented episode, then you will have to consider that as multiple.
Nice.
But if the patient never complained of palpitation, you cannot assume patient doesn't know that they have palpitation. That will be unwise. So it all depends on the history of the patient.
Right, sir.
Right.
Sir, what about the self-induced vomiting and valsalva maneuver? If we teach the patients like that, because they have very infrequent RSVT.
I treat my patients gag reflex. Because
I also teach my patients like that.
Gag works. Only thing is that if you never teach patient carotid sinus massage, never, number one. Number two, I teach them Valsalva and I teach them gag. Just make sure they're lying down when they do it or sitting down, because these are vagal maneuvers. They can actually cause blackout spell. All right, Hafiz, let's continue with the next case.
Yes, if this was not good enough, then go for the next one. 66-year-old male with past medical history of coronary artery disease, reduced EF, 40%. EMS brought the patient to ED and patient found to have a following rhythm.
White complex. Who wants to talk about it? Please raise your hand.
Vishal.
First of all, I tell the
Vishal Sreshta wants to talk about it.
junior physicians, please don't get intimidated by the EKG, because you need to take care of the patient. You are not treating the EKG, but the EKG can be intimidating, because this EKG looks like, kind of intimidating. Wadud, you will agree, right? That this EKG looks ugly. Right? So usually I try to find something very simple. Rafique Bhai will comment. If the patient is hypotensive with this EKG, life is easy. Shock, but or passed out. But if not, then you have a problem. My question is, exam-wise, nothing remarkable, and I gave you the history. Blood pressure, okay. If you two questions I have for you. What is the rhythm? And second, if you cannot answer the first question, still you can treat the patient. Comments, anyone? Maybe a senior fellow.
Shall I try, sir?
And Vishal, do you want to talk about it?
I want to try, sir.
Oh, well,
Sure.
please go ahead.
So, sir, this is a 12 lead ECG with rhythm lead associated, which shows white complex tachycardia at the rate around 160, 170, white complex regular tachycardia. It shows almost negative concordance in chest leads, and
Hafiz
ECG.
moved. Can you go back to the ECG?
Hafiz by ECG. Yeah.
No, I can't see the ECG. Hafiz.
The bar number slide to দেখতে চাই।
Okay, good.
Yeah.
Yes, sir. So there is a small R wave, and S wave. So concordance is not present. Then in V1, the R to S duration is less than 100 milliseconds, and there is no nodes. And there is, I cannot clearly see any capture or fusion bits, sir. And though and AVR, in AVR also there is a negative fast wave, and VT by BI is also less than 1. The terminal initial, there is more delay in initial part in AVR. And so my differential will be first, as the patient had history of coronary disease and he is hemodynamic unstable. So I'll treat him as a VT, but another differential will be SVT with aberrancy, sir.
Okay, can I interrupt you for a second?
Yes, sir.
All the points you said, excellent description, right? All the points that are present goes against VT.
Yes, sir.
So then why did you make your primary diagnosis VT?
Because the patient has history of coronary disease with low EF, sir, and he presented with syncope.
So what? Yes, that is very true. But if you look at the ECG, you described it very nicely. Rate around 185, 86 beats per minute. Left bundle morphology. QRS duration is about 160 milliseconds. Initial R in V1, V2, V3 is narrow, less than 40 milliseconds. Beginning of the QRS in lead, chest lead to the deepest point of S wave is less than 100 milliseconds in all the leads. Only thing that's funny is that in V6 there is still RS pattern. I think that's a lead position problem. And you did not see any fusion beat or capture beat. And all this description fits in SVT with underlying left bundle branch block or aberration left bundle branch block. And second will be unusual case of VT. Okay.
Yes, sir.
Anybody else, any comment on that?
Sir, Hafiz Bhai was saying that if you even don't understand what underlying arrhythmia is there, but you can still treat it. Hafiz Bhai, what do you mean by that?
Hafiz is mute. Hafiz, you're in mute.
Hafiz Bhai, unmute please.
Now, what I'm saying that patient is on coronary disease, EF bad, and this is wide complex tachycardia, and the patient has hypotension, then you keep that differential in mind and you shock. But if the patient has hemodynamically stable, you still keep that in differential. And question is, you need to be observant and go through the algorithm about differentiating between wide complex tachycardia, VT versus SVT. Rafique Bhai has nicely explained all that. Question is, can you give adenosine in this situation? Will you be brave enough to give adenosine? Or is there any bravery in giving adenosine?
What was the blood pressure?
Blood pressure was normal, 137.
Hafiz Bhai, one question was there. Is there a Cabrera sign whether they should consider it's an acute MI?
Consider that what?
Acute MI.
No. So the first of all, there is
Because
left
of the
bundle
Cabrera
appear.
sign.
Yeah, and then with this tachycardia, it is better. It's, this kind of wide complex tachycardia is like a paced rhythm. In the face of paced rhythm, you need to look at the clinical picture rather than EKG to tell you STEMI or acute MI. See, EKG is very unreliable. So I would not go by that. And then it is critical that we convert this rhythm to normal, then you do your
Yes.
analysis first. So
So for
I
the
was
juniors,
arguing,
can I interject?
yeah.
For the juniors, if the patient is unstable, what comes tachycardia? Just shock the patient.
Yeah.
If the patient is hemodynamically stable, you can try with adenosine, you can try with amiodarone. When you can have some time, and if it's possible, you can analyze the rhythm. But that's the thing Hafiz Bhai was mentioning.
And if you
Unstable,
cannot,
don't bother, go and shock.
and if you can't figure out anything, you pray. And if the blood pressure drops or the patient passes out, you are good. You can really shock. So the patient was shocked in this case because the emergency room physician was not liking this rhythm. They gave propofol and then shock, and this rhythm came after the shock. Same patient. Transiently came like a normal rate, and then boom, went to this.
Now never complex tachycardia.
So that proves this was SVT. Now, Hafiz's question is, will I be brave enough to give adenosine? Yes, I will be.
Yeah.
Because that means I'm going to have pads ready.
Yes.
Patient is not, if this patient was having acute MI with a heart rate of 187, patient will be very sick.
Yeah.
And so I have pads ready, I give adenosine. I've given adenosine to asthma patients with blood pressure of 90 because nobody wanted to give anesthesia to that person, and it worked.
Yeah.
So as long as we are prepared for the consequences of untoward effect of any of my actions, I think that can be done.
And you have a plan B, and you have a plan B and plan C available.
Exactly. So nothing should be done casually in this kind of patient. Oh, let's try adenosine. But I have in my mind, I have to have all the algorithm ready that if by any chance this is acute myocardial infarction, patient can get worse, but patient is not having chest pain. I have pads ready to shock the person if the rhythm changes in any other way, so that I'm mentally prepared. I think it's true for any procedure or action.
Hafiz bhai, can I go to the first ECG, please?
Yeah.
White complex before ECG.
What about the P waves?
Sir,
P waves are here in
Yeah.
lead 2 and lead 3.
Very beautifully
P
seen.
waves are looking at you.
Yeah.
sir, regarding the Rafique sir, regarding the ECG diagnosis, sir, that is R2S is very important finding in case of the BT diagnosis. Sir, can we measure the R2S in the limb lead, sir?
No. The R2S ratio is only in the chest lead, but that is in the setting of right bundle morphology.
Right.
You see, if you look at V5, V6, RS ratio is less than 1, but this is not right bundle morphology. This is left bundle.
Correct.
I think this one was mainly because the lead was not placed right.
Mm-hmm.
If they had put because if you look at lead 1, it's typical left bundle. Another factor, remember that I mentioned the duration of the QRS complex.
Mm-hmm.
With left bundle, if the QRS is 160 or less, it supports SVT. With right bundle, anything over 140 supports VT. So that is another factor.
And then another thing that in V6, Rafique bhai, V6 and there is no Q, there is a distinct R. If there was a QS, then it would be more supportive of VT.
Yes, but I'm very happy that the way we shall describe the ECG. It was wonderful.
Wonderful.
You did a great job.
I have one question. I have one question. So sometimes you give 6 mg adenosine, 12 mg and verapamil, and nothing changes. So what would be your strategy after that? In a hemodynamic stable patient.
Yeah, the reason adenosine doesn't work is the way you are injecting it.
No, you give fast flush, everything, full protocol.
You have to connect it with a 3-way stopcock. You cannot inject, disconnect the syringe and connect the flush. you have wasted 9 seconds. The drug has washed out, metabolite. So first of all, I use the arm. If I'm using the arm, I connect a 3-way stopcock. One has 20 cc flush of saline, other has the adenosine. I inject the adenosine, elevate the arm and inject 20 cc, and it will work. We rarely have to give. You can give up to 18. And of course, I mean, there will be cases where it will not work. But that is one of the commonest reasons for adenosine not working is even it happens here. They will flush, they will inject, disconnect the syringe and connect a flush. That doesn't work.
So I have a little different view than Rafique Bhai, of course. If it works, then I say, okay, it worked. If it does not work, then I go through the thing that maybe my administration is problem, or maybe my diagnosis is not right.
Oh, yeah, absolutely. No, Hafiz, I agree with that. I mean, if the appropriate injection is given in a right way and it doesn't work, and in some cases it is not going to work, even for SVT, it may not work.
Yes. Yes.
Or when you are off, your
No, we follow exact protocol, 3-way boosting. We get some cases like in that case. Now, what antiarrhythmic or you give us DC shock in this patient, despite using appropriate techniques.
Okay, the question is, if adenosine does not work,
yeah, patient is stable.
If adenosine does not work, I mean, you can start a drip. We try to give diltiazem drip. We avoid verapamil because verapamil can cause more drop in blood pressure, and so you can give diltiazem and see if it works.
And another tendency at this point will be to give amiodarone bolus. So this patient, this ECG now, what to do now?
Why not amiodarone?
Was that?
Why not why not adenosine?
Okay.
Yes. Did they give adenosine?
They gave adenosine, they reverted back to normal. And this is the part, Rafique Bhai, I need your help. So this patient then went to the EP lab.
Yeah. Yes.
So the working diagnosis was that this was tachycardia related left bundle with SVT. And then second EKG, it was SVT, probably AV nodal DNT tach. But the EP study showed something different.
Yeah. So
can you walk us through?
Yes. So if you look at, I'm going to look at the CS. It says P78. P means this is near the AV node. And if you look at 3 and 4, it is on the left side. So basically 5 and 6 and 3 and 4, initially there is a wide complex and then there is a sharp complex. The sharp complex is a retrograde A. So it's a left-sided accessory pathway, probably a concealed accessory pathway.
Wonder-full. And that was ablated?
Yes, means coronary sinus.
Yes.
So sir is talking about the catheter placed in coronary sinus.
Yeah.
Excellent. So and this was cured and patient went home happy. So now that we solved this, what do you think about this patient? So that was a good case, Rafique Bhai, and so and of course the interesting thing I just learned that when we are discussing, our electrophysiologist remained silent, and he had the final say. He did not commit, and when I said that it's left bundle, and he said, well, we'll see. So he actually proved it in the lab that this was tachycardia related left bundle and an accessory pathway. And the second EKG was really interesting. So it was fascinating and all good. So not necessarily all wide complex tachycardia with reduced EF. By rule, we entertain VT, but you need to pay more attention. But this was actually not so difficult because the P waves were so distinct. So it was very, very good that way. So this is another EKG. What do you think? Anyone?
You should. Is this the one you want to show, or you want to show another EKG before that?
No, this is different case. Different case.
All right.
Sir, can I try it, sir?
Yeah.
Yes, sir. Sir, to me, it is the 2 lead ECG, and here I can see the rate is around 160, 70, and the rhythm is irregular. I can see any P wave here. I can see the P wave. I can see the P wave before the in lead 2. I can see P wave before QRS complex. The QRS complex are somewhere it is slightly wider and somewhere it is narrower. And I can see here the rate of QRS complex. The QRS complex are irregularly irregular, and we can in lead second and lead third, I can see the delta wave with short PR interval. So I think this is the pre-excited AF, sir. Pre-excited AF in patient with WPW syndrome.
The Manoj.
Yes, sir.
So
yes, sir.
If it is pre-excited WPW, it is of course a possibility.
Yeah.
And if you look at lead 2, it looks like that. However, look at lead V4, V5, V6. There is a sharp initial R wave, right?
Yes, sir.
That kind of goes against a pre-excited beat. You are unlikely to see. And also in lead V1, V2, V3, there is no slurring.
Yes.
That's number one. What do you think of that? So
Manoj,
your
do you understand
baseline
the question?
Yes, sir.
So that goes kind of against, but clearly that's a possibility. The other part is that what is the underlying driving rhythm? Anybody, any comment on that? Fibrillation or something else?
What is the clinical scenario? Is the patient has COPD?
Excellent. You notice that usually I give history. In this case, I did not give any history.
Yeah.
So
if it is a patient of COPD, I can see these P waves with irregular.
Please, can you go back to the ECG, please?
Another possibility, multifocal atrial tachycardia could be the differential if patient is COPD.
Okay. Okay, so here is the history.
Okay, no, go back, Hafiz, please. Oh. Okay, look at lead 2. Last 3 QRS complex, and before that, there is a negative complex. So that looks almost like a flutter wave. And my bet is this patient has underlying atrial flutter with variable AV conduction. The reason I'm saying that, if it were multifocal atrial tachycardia, if I go straight up, I would have seen a P wave in lead V4, V5, V6. So my bet is atrial flutter with variable AV conduction with underlying left bundle branch block. And let's see what Hafiz says.
So I agree that a fib with pre-excitation is a possibility. A flutter variable block, and then question is multifocal atrial tach. But poor me, I get dragged into because of the ST elevation. I'm not and then I have to sort it out. So first of all, I told them, guys, this is a STEMI deactivation. This is not. But Wadud, as usual, asks the most interesting question. What is the clinical context? I deliberately did not give the clinical context. This is a patient with a hemodialysis, and look at the potassium and then tall peak QA there, and potassium was 6, and always I look at these patients with QT interval if possible, because sometimes they have hypocalcemia, hypomagnesemia, or sometimes hypercalcemia. But in any case, this patient got amiodarone, and this is the question for Rafique Bhai. After amiodarone, this is the EKG.
Yeah. So, I mean, this is, of course, now.
And the potassium was corrected, of course.
Yes. Sinus rhythm with left atrial enlargement and
left axis deviation.
Left axis deviation. So I still, I mean, I think Manoj pointed out thought of AFib underlying rhythm. I think the underlying rhythm was either AFib or atrial flutter with variable AV conduction. My bet is more on atrial flutter, and then rate dependent left bundle branch block.
Right. And the flutter fib versus the left bundle, all agreed. The patient has been in the hospital before in other hospitals and has been treated for atrial fibrillation. So he was sent.
Hafiz Bhai, can I ask you a question? What is the QT interval?
QT interval, yes, of course, it's a little bit longer, right?
A little bit longer.
Yeah, and this QT interval can be from the amiodarone, but amiodarone induced QT interval giving torsade is really low. But we did not keep on long-term amiodarone, short-term amiodarone, and then take it off.
This QT is 400 millisecond.
Yeah.
And the cycle length is 800 millisecond. If the QT is less than half or less than the RR interval, then we are in the safe range. Just it's a blanket rule.
Right. So, we have time. We have one more case.
Yes, yes, please.
Okay, non-ischemic cardiomyopathy, EF 25 to 30%, and an ICD, and the heart rate is 120, blood pressure 95/65. This is a tough one, but I only dare to show this because Rafique Bhai is here. So this is the EKG, right? This is the EKG, just have an eyeball on this EKG. And then what happened, that this patient went into tachyarrhythmias, and then the patient was getting shocked. So,
Hafiz,
yeah.
Do you have the ECG where it got shocked?
No, that is the problem. That is the problem.
You have it.
I don't see.
Can you move? Okay, wait. No, go back, please. Okay, this is, no. Stay slow. Go back, please. Go back.
Go back. No, this, I don't have any.
No, you have it. You have it. Go to the next one. Yes, stop there.
Yeah, this is actually from the interrogation.
Yes, this is good enough.
Okay,
this is where, you see, I'll show you. If you look at where in the top, there is ECG, and then there is a big movement, and that's where the shock is. And it says in the top 40 joule shock.
Right.
Okay. So, okay, do you want me to say something about it?
No, I just wanted to see anybody has any comment, then you. Because I did some tricky thing here.
Why the patient was shocked?
Sir, so because of the high rate and the irregularity, the device might have thought that this is VT.
Yeah. No, device did not think it is VT. Device thought something else.
VF. Okay.
Look at the first writing on the left. It says VT1.
VT2 and VF. Okay.
No.
Yes.
VT1.
VT1. Yes, sir.
Okay, and then VS.
Yes,
And then
sir,
it goes to VF.
VF. Yes, sir.
So the intervals, once you have that, after a certain time, the device commits to VF therapy.
Correct.
Yes, sir. Yes, sir.
But,
Exactly.
okay, question is it VF? Look
No.
at the intracardiac. When it says V-sense, negative, positive, negative. And exactly same morphology. And that's how the next two bits are a little funny looking bit, different. So
Yes.
I am looking at going backward from the first bit. Look at the first bit, negative, positive, negative. And the first negative is smaller than the second negative. But second, third, and fourth bit, there are probably some ventricular beats intracardiac, because this is a single chamber device, you can't say it.
Yes, sir.
And then there is some conductor. So there is some non-sustained VT, and it fell into the VF zone, and the device committed itself to shock. And that's what happened to this patient.
So, Rafique bhai, this is the question I asked to our electrophysiologist also, that there is no way the algorithm for the lead cannot be like defined that the intervals, right? The irregularity they cannot figure out. They'll go by the rate only, or they can figure out the intervals. Is the device sophisticated enough to understand the RR interval, or they go by the rate only?
Both. You can actually program intracardiac morphology. I don't know if morphology was programmed.
No, morphology was not programmed. But the question is, Rafique bhai, clearly it is the RR interval is irregular.
Yes. But even if it is irregular, remember VF is irregular.
Right.
So
Correct.
if you program regularity, you will miss VF.
Correct.
So VF is, so in those cases, two things we do. We increase the detection rate, number one. Number two, how many intervals you need to detect before you get shocked.
Right.
Those are
But
the
my
few things.
argument was that if it is irregular, but if you put the ceiling for rate high, because
Yes.
VF in a slow VF is rare, right? I mean, it probably doesn't exist, because then it might be okay. But in any case, this was programmed with higher rate and it gave amiodarone.
What device is this?
You got me there. This is actually
It's a Biotronic.
Biotronic, yeah.
A terrible programming. You know, this thing, I don't know. Somebody have to sit down with this program and look at it, because why did it commit so quickly? So I think we're going a little bit beyond our audience level.
Yes,
so let's skip it.
But let me tell you why I showed this case, Rafique bhai. Because it was increased VF zone to 210. And the reason I'm showing this was a diagnosed non-ischemic cardiomyopathy. When there is a device shock and question about VF and EF bad, we are obligated to do ischemic workup. And that was the pressure on me. And I said, this is luckily cath done. We don't need to do this again, because this was not a VF issue. And therefore, I did not do another angiogram.
How long are you going to give amiodarone to this patient?
Okay, so I usually follow 6 weeks to 3 months, and then try to wean off, because I don't want to keep it long term. But it all depends, because in the follow up, if you have issues, then because I don't like long term amiodarone. Rafique bhai, you have any comment?
Well, this case is a little different. This is not VT related shock. It is inappropriate rate control.
Right.
So the first target will be maximize beta blocker.
Yes.
Second, reprogram the defibrillator. Third will be, despite that, if the patient continues to have shock, not amiodarone, because amiodarone, we may have to consider AV node ablation with upgrade to BiV, because this will become a chronic problem a long term.
Yeah. So we actually maximized the beta blocker, amiodarone. It was so far been okay, but that was another suggestion. But I wanted to try maximum before we bombard the AV node.
Yes, no question.
Yeah. Okay, maybe the, no, let me show you this wild case, because this we are going to publish. 65-year-old male. This is general cardiology. COVID and respiratory failure, and echo was reported as tamponade. Will you agree that this is tamponade?
Why are they saying so?
Because if you look at the RV, in front of the RV, there is little echo-free space, right?
Yes, but not tamponade.
Not tamponade. So now we give contrast, and look at the contrast immediately going into the area.
Oh. Rapture হয়ে গেছে।
So this is the CT. The CT showed that the right, the corner is, we see the left atrial appendage, and this is right atrial appendage dilatation. Huge. And it was like a bystander finding, and did not need anything done. But we were ready to do operation if there is hemodynamic instability. So far has been okay, but we are nervous. We probably will need a surgery, but this is like a rare finding, very, very rare. But I'm saying that a thorough study, this is actually one of my ex-fellow, now an attending, he did not buy this idea. Patient was almost going to the OR for pericardial window, but he saw this and was not convinced that this is a pericardial tamponade. As Wadud pointed out, it did not look like tamponade, right? And it is just, then somebody said it is localized, but then my fellow was, my attending now, he was absolutely brilliant to order a CT, and that defined very well. Yeah. So without that, it could have been a problem in the OR. We may need to go to the OR because it is just the size. It is still not hemodynamically compromising. So I thought that I just show this interesting, but we are going to publish this. And I think this will go. Thank you.
Atahar, would you make some comment?
But one thing I wanted to request the participants that when we interact, sometimes we want your participation. Today, both of you did excellent. Think logically, keep a differential diagnosis in mind, and don't be intimidated by the EKG. The patient is in front of you, and you observed how Rafique Bhai walked us through this problematic EKG.
So thank you, Dr. Hafiz Bhai. Really, it was a brilliant and excellent session today because of the combination of you with Rafique sir and the participation from our two participants nicely participated in today's discussion. I think this is a good approach, sir, for learning perspective. This is a good approach for the discussion, and calming the participants in interaction. Sir.
Yeah.
Sir, from the January 22, sir, we have decided to do the session in every second and fourth.
Okay.
Sunday.
Second and second and fourth, same time, sir, 9:30, same time. And each day there will be one, that is the 30 minutes basic discussion, and followed by your, that is the case-based discussion, particularly from you and the Hafiz Bhai, and sometimes from the our some participants, and also from Dr. Raziv Bhai, sir. Sir, what will be the idea, sir?
I think that's fine. Every 2 weeks is good. And
I have a request for the faculty. Rafique Bhai, what do you think if we nominate, Wadud and Atahar Bhai and Jamil Bhai and Professor Azam is here. Can we nominate 3-4 people from different institutions that, when they can volunteer that, so that we know that we can let them know that the cases will be on wide complex tachycardia or something. So they can be little more active, because sometimes I think our fellows and residents are a little shy, and they think that, I don't want to talk. But trust me, if you talk and if you participate, it is more fun, and also it is very educational for yourself. And I think we encourage that. But maybe we start with nominating people, and then it will be free for all.
I think this is a good idea, and we'll try to arrange it.
Okay.
It is possible, I think.
Okay. I think we are out of time today.
That's the way actually Atahar Bhai has scheduled the whole thing. Atahar Bhai, can you send it to Hafiz Bhai and
Yes, I have already
Rafique
sent.
sir, and also to Arun?
I will resend it again.
Take their comment about it.
I think we should ask Mohsin to give at least one talk, one presentation.
Yes,
Okay,
yes,
sir.
yes. I want him more active, but he doesn't talk too much. Mohsin,
sir.
with your knowledge, I want more active participation.
Sir, I am listening everything, sir.
I know, but I want your active participation. You are passive. You know so well.
Rafique sir is here, that's why I am thinking.
Okay.
Thank you,
I
sir.
think we should conclude the session today, right?
Yes, sir.
Thank you, Excellence, for today. Wadud Bhai, wrap up it.
Thank you, everybody. And we really enjoyed it. We changed the format a little bit for active participation. I think there's more of an intellectual incursion between the exchange between the teacher and the students. And that's very good. Ribhu, your team is excellent. They are helping us throughout this pandemic era. We are really grateful to you. And Hafiz Bhai and Rafique sir, as always, extraordinary. Arun, your students are really good, and they are very courageous to speak up like that. Chitraraj Sharma, Vishal Shrestha, Manoj Koirala, thank you. And all the participants who has been present here, thank you, everybody. Good night.
And Arun Maski, we are expecting your students volunteer every day.
Yeah, sure. They will volunteer. Sure, thank you.
Thank you very much.
Sir. Sir.
I will send you the program, Arun Maski.
Yeah, sure, sir.
Yeah.
Sure. Thank you. Good day.